in order to download, so we're going to download some more models to talk about statistical modeling types. And to do that, we're going to go to that folder that we were in before, that participant resources and these models for possible examination in class. Last time, we downloaded only one of them. This time, we're going to download a set of them, okay? So the first thing I'd like you to download would be a model here, which is, okay, let me just locate it here. Right, it's this GIS food environment with adding supermarkets. Do you see that? This is a food environment. I'd like you to download that, okay? Next, I would like you to download this interaction of weight and diabetes Melbourne. Okay. So that's a model which incorporates some health economics considerations. I would like you to download additionally one that is called Total Value Stream Services Expansion. It's down there just below smoking disparities. Okay. We're going to be using that as an illustration of some health services work. And just looking here, being mindful of the time, I think maybe we'll limit it here to those couple here. And now, having downloaded those, I would like to go open them up, okay? So to open them up, we're going to go to AnyLogic, and I'm going to close out. I had this model open. Maybe for you it's already been closed. File, close, okay? We're going to close those things, and now we're going to open one of those other models. File, open, and the first one that I'd like to open will be a contrast to what we've seen already. And this will be this total value stream services expansion, okay? We're privileged, ladies and gentlemen. Really, it's an honor to be working with our Ministry of Health in the context of the work on the ED Weights and Patient Flow Initiative. And one of my students that you'll be meeting this afternoon first went and introduced that team, the Ministry of Health team working on this, under the direction of Graham Fast and Jenny Basran, to dynamic modeling. His name is Kurt Kruger. You'll meet him. Another one of my students, Yuan Tian, is currently the sort of lead modeler with that initiative over at HQC. If we open this model, you'll see something rather different. There doesn't seem to be a theory of personhood that's depicted in a person class. Remember before we had person, we double-clicked, we could see a person could go between different states, and they could be pregnant or not, and they could have these different smoking states. Here, what we're seeing is rather different. What we're seeing is a higher level depiction. It's what's called an aggregate depiction. And this type of modeling is called system dynamics modeling, okay? It is often, although not always, applied at an aggregate level. Sometimes it'll be applied within an individual. Here it's an aggregate model, which is in health where it's been most commonly applied historically. And the US CDC has a series of models, the PRISM model, a diabetes model, that use this technique and that have been fairly well published in Health Affairs and other journals of note. Here, what we see is a depiction of the population as divided into a set of categories. And you'll notice it's a little bit confusing. How did I get here? I scrolled up when I first opened it. I had to scroll up, and I used the scroll bar over here to scroll up. So here we see people divided into a set of categories. Those in community, those who have arrived in the ED, but have not been triaged yet, those who have undergone triage, they're registered and they're awaiting assessment. Here are some that are assessed and awaiting disposition by a doctor They've been seen by a clinician, and they're awaiting disposition. And then individuals, if we scroll over here to the right, who have been examined by that physician and a disposition decision has been made, they will go into one of a set of states here, okay? And I'm going to focus on these states down here where they're waiting for a bed, they're moving to an acute bed, to an acute care bed. And you'll notice those acute care beds are taken up by those patients, but they're also taken up by those coming from elective surgery. And then following some acute treatment, they're awaiting transfer to community options. You'll notice that it goes to the community here. And there's a need to transfer them often to long-term care or other facilities, potentially to home care, etc. Now, some individuals go on to be what's called ALC patients. These are alternative level of care patients. They're occupying an acute care bed, but they're not needing acute care services. And they're represented here, and some of them flow out to long-term care from acute. Some go to other options. So this model was built by Kurt, although this is not quite the model. It's been, for reasons of privacy and so on, we've kind of fudged some of the data for this particular model, so it's not exactly the model Kurt built. We've noisified the data, hence the name up here. But this gives kind of a map of the process of acute care and its link with the community. And I told you that a lot of what goes on in dynamics of ED is actually dependent on what's going on downstream here, going on in terms of acute care beds. This waiting for bed backs people up. But in addition, there's a lot that goes on in the community and driving people in. This model was a more constrained one. We simply represented ED arrivals by hour of the day. Okay, so here we're taking a look at the ED arrivals per day, and if you go and look at this so-called flow, which brings someone from this state to another, there's a certain rate of people that are going down there. The number of daily arrivals times the arrival, sort of an hourly arrival coefficient. And this hourly arrival coefficient is defined arrival to ED fraction. This is defined over here in the functions area, arrival to ED fraction. So I expanded this over in projects, and you'll see by hour of the day, we can have a certain number of people arriving. And this was determined historically. How the patterns of people's arrival during the day, what fraction of those who arrive during the day arrive at certain hours. Okay? So it kind of distributes those over the day. Yeah?
Why aren't there, maybe this isn't fair because it's not what we're talking about, but why isn't there fixed parameters like socioeconomic status?
Good question. So models have scopes. This model was one of two built in a 3-month period by the intern. And it was designed as a project to explore the use of this modeling and what it could be used to do, and to figure out if this was a long-term investment strategy they'd like to make. And within 4 months, it was deemed, given that there are two models involved, it was deemed to be difficult to access all that data. We later have gone back, and UN, who it's possible you'll see in a cameo today, UN has gone back and actually, it took her probably 6 months to get access to all the requisite data. She had to go through all sorts of things with not only SHIPs, but with provincial data sources, et cetera. And she's been able to get a massive amount of data that can additionally get certain types of risk factors, et cetera. Rural urban is another interesting one, but that was not something we could do in 4 months' time. So it was outside the scope of this. This model did convince them that it would make sense to make this a long-term investment and do put in the requisite needs. However, I will say beyond that, that when it goes to incorporating certain factors, there are certain tests that you want to perform. So when it comes to incorporating an aspect of heterogeneity, maybe a socioeconomic status, you're going to want to do some tests with the model generally to figure out, is it sensitive enough to the factors that will be affected by that to be worth the time of adding that in as an additional factor? There are times with nonlinear models, and for reasons that I don't have time to fully explicate right now, but we could talk about this afternoon if they were interested. Models like this are often what are called nonlinear. And what that means is that among one of the many implications of this is different parameters have very different levels of sensitivity. Certain parameters the model may be quite insensitive to. You could change it by a factor 50%. It will have very little difference for the model. Others are very sensitive. And so generally what we do is we build a simpler model up front, and we try to do so in a very step-by-step way where we add one factor at a time in, and we test sensitivity as we're doing that to evaluate would it make sense to expand in greater detail certain parts of the model. If it's very sensitive to this assumption, maybe it makes sense to represent it in much greater detail. And so before adding in heterogeneity of a certain sort, let's say rural-urban, or let's say it's an aspect of socioeconomic status, or some other aspect of chronic disease risk factors or mental health issues, before adding those in, you probably want to do something to test the sensitivity of the model to that result, because time is limited, and we can only put in a certain amount of factors into the model over time and still make progress. And so the idea is that we triage over time as we learn from the model. And this is an iterative learning thing where we're actually building the model, testing its sensitivity, figuring out how to expand it, and working accordingly. So that would be an example of a risk factor that might be relevant for certain types of care seeking, that you might want to take a look at the data about arrivals, figuring out how much of it might be SES related, if indeed there's good understanding of that. Trying to figure out how much of it is coming from individuals in different areas, urban, rural, or what have you. But building these models is best pursued as a stepwise learning from a simpler model, adding things in as you're convinced that it makes sense. Because one of the biggest dangers for these models, I'll get to you in just a sec, one of the biggest dangers for these models is that they can grow to be so large, it's hard to understand, and it is hard to use them as effectively, and it is hard to make progress because there's so many factors involved that it becomes very challenging to advance it, to examine certain interventions, for example. So you start small, you start adding things in as it seems to be needed to explain the empirical data, as it seems to be needed to investigate certain interventions, as it seems to be important for more accurately capturing the outcomes. And that is a learning process. They're works in progress. Yes?
I guess in the case of the example,
Yeah.
would you ever consider analyzing it, for example, the big tertiary care costs in emergency department so different than a rural ED? So would you ever be able to stratify it, looking at this?
Exactly.
Yeah, and then doing the model separately versus just for the whole.
Exactly. Great question. So the technique which is being used, and again, you may hear more about this from Kurt or Yuan this afternoon, is the way this project is going, responsive to the question that was asked previously as well. After their big investment in this, one of the components of that has been to create different models for different centers. So for example, there's a partnership with Kelsey Trail Health Region up in Tisdale to build a model of a smaller facility there that has flexible use. There's a different model made for RUH than for City Hospital here than for St. Paul's. And RQHR, there's been some modeling specifically for the hospitals there. So each of those, they've adopted a different representation of the hospital because they're so different in terms of some of the admissions patterns, the role of ED, the role of elective surgery of different sorts, and the acuity of the patients arriving and the level of complications of the patients. Okay. Similarly, you might actually, this model was again a very early one that I'd like to use as a teaching example because it's simple enough for students to appreciate. But one of the things that has been done since then is taking apart the different classes of patients. You could think of as CTAS scales, 1 to 5, but there's also an issue, so acuity scales, but there's also an issue of, for example, individuals who have mental health issues or chronic disease issues. We know from hot spotting that those actually occupy a very large fraction of ED visits as individuals with those characteristics. And so you might disaggregate those arrivals so that they're not just an arrival, but they're an arrival of a patient with complex chronic conditions that require a more complex treatment pathway associated with them. So the episodes of care associated with them might be longer, et cetera. So that's been a big point of emphasis. Okay. So this is a little teaching example, but I'd like you to run it. You can go run it here, and one of the things you will find is that this sort of model can actually be quite interactive in the sense that it can run very very quickly over time. And you'll notice that there are assumptions up here. In addition to being sort of various displays, there's also assumptions up here about the capacity of the time to disposition decision that can be modified. So for example, we can ask, suppose we could modify the time to disposition to 2 hours, for a certain period of time, for example, how would that end up affecting the dynamics? I just changed it to 2 hours time to disposition. And one thing you can see is this kind of this flow of patients through here, right? You'll notice that these are different classes of patients. Those are assessed for the ED, registered. Those are waiting for the bed in the ED. Here's various acute patients. But if we change this time to disposition to something much higher, if we change it, for example, to 8 hours, now we're going to see very, very large levels of sort of people waiting for EDs, and it has a corresponding impact on acute care. Similarly up here, I believe these are the arrivals here. We'd have to go unpack that. You can in principle change some aspects of the arrivals per day. Daily arrivals here, if we lowered it down to 100 arrivals per day, we could see, how would the system behave given the flow here, given the structure of the system? People arrive, they go through these stages. There's these levels of time needed to advance them. How would that end up affecting their flow here? So this is what's called a system dynamics model. To be clear here, each of these boxes here, let's take a look at these individuals who are registered and awaiting assessment. So this is someone who's undergone triage and they haven't left without, notice that there's this left without being seen here, this LWBS. These are people who have left without waiting for medical advice. And we can go and we can actually click here and you'll see there's some number of people in this stock. This is called a stock. It's a state variable. It represents an accumulation. It's sort of people waiting there. And people flow in and flow out. The flows represent the change, but this is kind of a pool of people. You could think of it as a bathtub with this number of people in it. And you'll notice that the number of people there varies according to the arrivals. And if you look at left without being seen, you also have some variation associated with that. So how did I do this? I click, And then there's a little graph thing here. Do you see that? It's a little, when you click on one of these boxes, there's a little graph thing. Do you see this thing here? You can click on that to see a custom graph of just that. And you could do the same thing with flows. Flows represent the number of people per unit time that are flowing down from here to here, okay? So this model has time associated with it, like dynamic models. You'll notice if you click on the model as a whole, it says the time unit is hours, okay? So these, for example, time to disposition is 8 hours. And once again, we could change that to something like 2, okay? So there's all these different controls up here. And we can ask what-if questions by running this model over time. And we could get reports on sort of outcomes. Here's long-term care net inflow per day, ED net inflow per day, et cetera, by changing things. And you notice you could change assumptions about types of patients. For example, what fraction in acute care need long-term care, or the fraction in ED that need acute care. So this is the result of some student work Kurt did. A fine job. He was quite early in learning modeling when he did this, so it's a quite simple model compared to what someone like Narges might be able to do these days, or someone like Aiden or Anahita, the TAs here. But it's an illustration of this sort of modeling. Aggregate stocks. Everyone within one of these stocks, this is just a count of people, and everyone within that is viewed as kind of being well mixed. In other words, they're not distinguished from each other. They're kind of all of a kind. There's no individual histories tracked here, and that's a big difference. No individual histories are being tracked here. So you can't ask in a model like this, how long on average did someone, or you can't ask, tell me the distribution of how long patients have taken to go from ED through to ALC status. You can't ask that because there's not the ability to articulate things at an individual level. This sort of modeling also can get unwieldy if you have to consider additional levels of heterogeneity. For example, urban, rural, low SES, high SES, individuals with mental health issues or complex chronic conditions. Once you start dealing with many types of dimensions of heterogeneity, it gets awkward with this sort of modeling because each of these stocks needs to be stratified by all of those levels, okay? That will be in contrast to the sort of modeling we saw earlier, and we'll see again in just a minute. But this sort of modeling is exceptionally effective for interactive exploration, for very quickly sort of sketching out a system, reasoning about where you might intervene, if not how you intervene. Often we turn to this sort of modeling as the first cut, try to measure sensitivity, and then we'll go to a more detailed model. And that involves a lot more detail. But a model like this can be created quite quickly by a talented person. There are limitations on it. We can't ask for interventions, to evaluate interventions that depend on an individual's history. That's really not a feasible thing, except at very sort of simple situations. Models like this are also really nice. Aggregate dynamic models are also really nice for pursuing together with big data. So Anahita back there is sort of the queen of this. And she's done a lot of work with models of this sort, hitching them up to data streams that might come from a ED admits, for example, or bed capacity, or occupied beds, or hitching them up. In her case, she was looking at number of individuals reported as being diagnosed with a certain communicable illness over time. And then you can use a model like this to incorporate that data live and to project forward based not just on one interpretation, but kind of a distribution of possible outcomes. Very powerful technique that I'm sure she could show you over lunch if you were interested. But it's a way of keeping the model abreast of the latest evidence, incorporating that evidence to the current situation, and looking forward from that latest evidence, okay? So, system dynamics aggregate model. I provided some slides on this that people will be welcome to review separately. I'm not going to have time to go through them myself here, but I will just point out here, and I'm going to go through a bit, that this is the first of the types covered, system dynamics. And system dynamics does also offer qualitative means of illustrating a system. And this type of approach can be very effective to use with system stakeholders to elicit understanding. Ladies and gentlemen, building these models is not purely a technical exercise. I know you probably think, you look at me and you think, I sit in the back office, turn off the lights, and I geek away at these models. And truth is, I do that a little bit, but less than I like these days. The truth is, building models occurs in the human theater. Building models occurs in the theater of stakeholders. It occurs in a theater of needing to build confidence in the model on the part of diverse people within the healthcare system. It occurs in the context of wanting to help ensure credibility by keeping feedback going from stakeholders when the model is yielding something that doesn't look realistic that they can zero in on it. And often it's not until a model is built that certain information comes out from the stakeholders about what they've observed. You might think that we could go talk with a stakeholder about their observations of patterns of care that are offered in an acute care context, or we can talk with stakeholders about mental health service seeking within the province, and elicit the information we need for the model. And we can do that up front, that's a good thing. But a lot of the time, it's not until the model runs and we show them some of the results that they can actually point out things that have remained tacit. They never thought to mention something. And then they'll say, oh, that's very similar to what we've been seeing. Or they'll say, wait a minute, you're way off in this. I've never seen anything like that. It's about 5 times higher than I've ever seen. In which case, we know we have to go back to the table and change it. So my point is that if you want to build useful models that get used by people to make decisions, whether at the local, regional, national level, you need to engage with the human theater. You need to work with stakeholders of diverse sorts. You want to build a model often together with teams, with stakeholder teams that are capable of using the model. So this model we just looked at, Jenny Bazran could use that model and run it and sort of look at the outputs from it and provide feedback to Kirk. He was running that model next to others in the ED Waits team to solicit their comments on it, on the results. And increasingly in our work, you'll hear about this afternoon, for example, with Alberta Health Services, the stakeholders run the model. They run scenarios. They are trying out interventions, they are testing the model with different parameters, etc. And that's really what you want to build the model gets embraced by the organization. And one starting point for that is to build diagrams from the start that illustrate people's thinking on an issue. These diagrams are not fully quantitative. They're what I call semi-quantitative. You'll notice there's polarities associated with arrows. These are called causal, not casual, but causal loop diagrams. And they are a notable feature and a very powerful feature of system dynamics. And they can be used for more qualitative features, such as the link between toxic stress and allostatic load, or allostatic load, like the development of chronic diseases, or between factors which are quite quantifiable. So models often start with some discussion with stakeholders that use diagrams like this to get discussion going, and then they proceed to more quantitative levels of modeling, okay? So with system dynamics, what we have is sort of stocks and flows. The stocks determine the value of the flows, and the flows dictate the rate of change of the stocks. Okay, and within models like this, we are seeing a dynamics of the system factors as a whole at a higher level than what we were seeing in that previous model, which depicted particular individuals. So we're seeing dynamics of sort of counts of people who match certain categories, and the flow represent sort of people changing categories. And as I said, these models can be used to kind of look forward, where even a really bad model, as long as it's corrected periodically, it can give really good projections over the short term, and it's always kept honest. As noisy data comes in, we form a consensus estimate and look forward. So system dynamics models capture dynamics of continuous variables. They focus on feedback. So you'll notice this in this diagram back here, there were a lot of what I'd call aspects of reciprocal causality. So for example, stress levels in a mom might lead to, or in a child for that matter, a child might lead to higher levels of maladaptive behavior, which lessens social support available, which can lessen the capacity to co-regulate and higher levels of stress. And you can get these kind of reciprocal, almost vicious cycles sometimes. And then there are regulatory cycles involving stress levels and self-regulation. On the part of a child, it might be sucking their thumb. On the part of a parent, there may be strategies for co-regulation of a child's stress that a parent learns that can quiet down a child and can help deal with it. And that can help prevent vicious cycles involving toxic stress and chronic diseases and intensity of stressors. So these sort of diagrams are often a first step used even with non-technical stakeholders, very non-technical stakeholders, and that's one of their advantages. So there are colleagues of mine, Peter Hoffman at Washington University in St. Louis is probably the foremost among them, George Richardson at University of SUNY Albany, who build these sort of diagrams with community partners. So they actually go as part of participatory interventions. They'll go to a community, talk with them about their understanding of stress in schools, so factors related to suicide within schools, or factors related to the high levels of obesity in a community. And they'll talk with church groups and other members of the community to elicit their perception in the trenches as to the connections in place. That doesn't give you a quantified model. You can't run this directly. But it starts to give you a sense of, at the least, their perceptions of the situation, which are pretty important often as a consideration when undertaking policies or interventions later. But it can also often sort of clue you into certain connections you didn't know were there. So causal loop diagrams are a big feature of system dynamics, and system dynamics as an approach tends towards somewhat simpler models, very quick to execute, can be run interactively with stakeholders, and are discussed with stakeholders on an ongoing basis. So it supports really rapid model prototyping, participatory modeling. It's a very well-defined area, group model building, and you basically build the model with virtually no programming in a traditional sense. There's some mathematical thinking, but it's no programming. And then you can reason about the possible behaviors of the model in a much stronger way than you can with an agent-based model, the types of models we'll see next. Okay? System dynamics modeling, aggregate depiction. We're counting the number of people in different categories, not following individuals. Okay? This is one system dynamics model. I provided you others as well. If you were to go there, if you were interested in poking around, I'll just point them out here. For example, basic health economics has some system dynamics components associated with health economics quantities. Environmental contamination uses system dynamics to capture levels of pathogen building up at facilities over time and as it decays due to cleaning and other factors. But there's also a coupled SIT model. This is a model where we have the time taken to secure treatment depends on how many people are waiting for treatment, and there's a spread of infectious disease which can be worsened by longer time to treatment. It's treatment-mediated disease. One I will open now, and I'd ask you to download, is this SD Diabetes in Saskatoon. Do you see that on the site? It's called System Dynamics Diabetes in Saskatoon. So I'm going to download this. Okay, who needs TA help? The TAs stand ready. Okay. SD Diabetes in Saskatoon. Okay. This was a little model that we built with some kind help from the Saskatoon Health Region some years ago, but it's actually started to be part of a much larger model involving diabetes and diabetic end-stage renal disease in the province, which has led to a whole series of publications, our work in that area, some of which you may be familiar with. So I'm going to open Diabetes in Saskatoon, and I'm going to use this as an illustration of some of the challenges of heterogeneity. So I'm pointed to it, and I'm going to open it, and I probably should have closed this other one, so apologies, I should have closed it, the other one, but both can be open at the same time. So Diabetes in Saskatoon was built as a master's student project, and it involved trying to reason about the linkage, the drivers for diabetes, for diagnosed diabetes here within the Saskatoon Health Region. And it includes a variety of factors that are notable, including weight. So I just opened it, and I'm opening Maine. I'm double-clicking on Maine, and here's Maine over here. That's where the system dynamics aggregate models will live. And you'll notice here within this model is a lot going on. This is not a model we build in our boot camps like some of the others. Here, this is a normal weight general population. An overweight general population is below that, and an obese general population. And individuals who are obese and overweight have a particular risk, and I'm scrolling over here to the right, to develop prediabetes and full-frank type 2 diabetes. So here we have an undiagnosed pre-diabetic population, and we have a diagnosed pre-diabetic population underneath that. To the right of that, we have a diagnosed diabetic without complications and an undiagnosed diabetic. One thing that's very important here, who needs TA help? So I'm just kind of walking through this model from left to right. I started back here with obese, overweight, and normal weight. And then I worked my way to the right here. There's undiagnosed pre-diabetic and diagnosed pre-diabetic. One thing that's very important to note is there's a lot of, as is typical for this sort of model, latent factors. By latent factors, I mean factors that are not directly observed. You may ask, well, how is it that the model's depicting undiagnosed diabetics? Well, remember, models like this, ladies and gentlemen, are different from your most traditional statistical models, which may deal predominantly in observables. These days, as we know, many statistical models at the cutting edge are positing latent factors. There's latent classes, or there's latent variables present, relating factors. And like those models, in these sort of models, we're often including in our theory of the world that there's undiagnosed individuals. Now you may say, well, okay, but how do we know how many of them are? And that's a good question. Well, first of all, there are spot screens that go on as part of community activities. So there are Saskatoon Health Region has run, screening initiatives where there's some measurement of individuals who are drawn from the population and are found to be pre-diabetic. So there's some estimates, and there are some studies which we were able to draw on, which could give rough guesses. But the fact is, ladies and gentlemen, we probably don't have a particularly great estimate of what this is initially. But this can only be within certain ranges for the data we see about diagnosed diabetes to make sense. And that's what a model like this can help us do. It can help us reason about, among other things, what possible levels we might see in prediabetes to jibe with what we do see in observables. because in a model like this, they're all linked together. If there's lots of undiagnosed pre-diabetics, it's going to end up coming out in the number that go on to either diagnosis, to become diagnosed, or the number that go on to be undiagnosed diabetics without complication. Because there's a structure here. If they're pre-diabetic and they're undiagnosed, either they're going to get diagnosed as a pre-diabetic or they're going to flow over here. Their diabetes will worsen. And then they're more likely each year to get diagnosed. The symptoms will be more obvious associated with their condition. And if they don't get diagnosed there, they'll come over to a stage where they have early stage macrovascular, and they're yet more likely to get diagnosed. So this model, ladies and gentlemen, depicts the progression of individuals among categories, some observed, some not observed, and allows you to reason about how would the unobserved quantities, the latent ones, like the number of undiagnosed diabetics, how would those affect the ones that are more observable, like diagnosed diabetics? If by combining the techniques in which Anahita is an expert with techniques from this sort of modeling, we can actually arrive at distributional estimates for the number of undiagnosed diabetics out there to make sense of the data when we combine this with administrative data, which we have. So we have 25 years of administrative data stratified by age, etc. Now the other thing, age, ethnicity, and sex. So another thing I want to emphasize from this model before we move on, and move on we will, is if you go here and you look at each of these stocks, okay, now, here we are. You'll notice that each of these stocks, each of these kind of bins, each of these collections of people, it has a little brackets after that. Do you see that? See these brackets? Those brackets indicate that it's subscripted. So here we're keeping track not only of the total number of overweight people in the population, we're keeping track of it by age groups, by ethnic groups, and by gender groups. Okay? So this model is actually highly stratified. And if we go over here to the left, we'll see that for age groups, ladies and gentlemen, we'll have 17 age groups. Basically, it's 5-year age categories and then 80 plus. We'll also have gender groups, male and female, for example, ethnic groups, etc., and in fact, weight groups. So this is a model which depicts a stratified version of the population. In contrast, that previous model just had one stock, one number for the number of people who are registered to weighting assessment. This other model, this new model, has it broken down by age group, by gender, by ethnicity, and that allows for greater descriptive ability to characterize the data. Okay? Okay, so let's close both these models. File, close all. Now, I see a lot of movement back there, and far be it from me to be wanting to be between you and your lunch. But let's go here to File, Open, and I'd like now to load in one of those other models, okay? I'd like you to load in a model that's this interaction of weight and diabetes Melbourne, okay? That was one we just downloaded. Interaction of weight and diabetes Melbourne, okay? This model, ladies and gentlemen, will be a different sort of model. It'll be an agent-based model. It's actually a bit of a hybrid for reasons we'll come to, but I'd like you to double-click on person. We see the signs that it's an agent-based model in that it has personhood. So this is a model we built in one of my boot camps in the fair city of Melbourne, almost exactly a year ago. When I was giving one of my boot camps there, I gave 2 back-to-back boot camps. This one is for Deakin University. And here we have individuals depicted with respect to their glycemic status, and we just had 2 glycemic categories, normo and diabetic, and then with respect to their weight status. Now, what's notable here, what is worth remarking on is, first of all, that someone's likelihood of developing diabetes here depends on their weight status. Okay, So there's something called interaction diabetes and weight. That was something that that people decided on as a name for it in the group. Interaction diabetes and weight, and that factor basically took into account their current weight status. So you'll notice if you go to these states here and you click on them, each of them assigns a value for interaction for diabetes and weight. This basically is a hazard rate. Okay? So as one gains weight, the hazard rate associated with developing diabetes rises. So one has a higher chance per year of developing diabetes if one is obese compared to overweight. Okay? Here we keep track of an individual's birth date, here called birth time, their sex, and we further are keeping track of their age at their first obesity episode. This is notable. Ladies and gentlemen, in a model like this, in contrast to that aggregate system dynamics model, we can actually keep track of their history. At what age did they first become obese, for example? We can actually track their history of events over time. For those interested in service seeking, we could record all their episodes of care, for example. The number of times they went in to the ED, or the number of times they visited their primary care physician. We could further keep track of, for example, when they were diagnosed with diabetes or when they transitioned to a diabetic state without yet being diagnosed. These are all things we can maintain because we're modeling people at an individual level. So if we were to go run this model, which I'd invite you to do, what you will see here is a depiction which incorporates that, but it also depicts another feature that we'll come to in just a second. So here we have people in the population, and people of different sizes. I think this is again a model we built during the boot camp, and it's partly to illustrate what could be done. But I think red and green is diabetic individuals, green is non-diabetic. The size of the figurine is illustrative of their weight status. So not surprisingly, most of those that are diabetic tend to be somewhat larger in terms of their weight status. But beyond that, you'll notice there's something in front of this, and it was something that aesthetically could be improved, to be sure. But does anyone recognize what is this in front of that? What is this here? What does that look like? These kind of boxes and arrows into them. Where did we see that? Within the past 15 minutes. Where have we seen that sort of notation? It's over here in Maine. Where do we see that sort of notation? This is system dynamics, ladies and gentlemen. Here we have a model which depicts individual agents, but it depicts them in a way which leads to health cost outcomes and quality outcomes which are recorded at an aggregate level. So we've accumulated quality adjusted life years lived, and we have accumulated costs and discounted costs, and in fact discounted qualities. Those quantities, which are sort of summarizing the quality of life over time of the population, the costs being borne, those are totaled up from the population of the whole. So if you click on Maine on this new costs, you'll see that this depends on the total costs across the population. And that total costs across the population, ladies and gentlemen, is something that itself is going to depend on the states of the individual. So total costs, if we go to total costs across the population, it is totaling up across the population, the total costs there, and the total costs across the population is for each person totaling up their costs. How are their costs determined? Well, you'll notice that their costs are going to be a function here of their current state, okay? So here we have total annualized costs. If they are diabetic, then we're going to return annualized costs according to their weight status for diabetics. If they are not diabetics, we'll return the costs associated with non-diabetics by their weight status. So in short, ladies and gentlemen, we have costs borne for different individuals by their weight. This here, I've just clicked on this guy down here, which gives for successive levels of weights, normal weight, normal and underweight, overweight and obese, the costs per year for a diabetic. And then similarly, this one for a normal glycemic person. Okay? So these costs are being determined at an individual level, and what's going on in Maine is it's totaling them up and accumulating them. It's accumulating them in terms of the total accumulated costs and in terms of the quality adjusted life years lived by that population. Where does it get quality of life for? Well, let's go here and check. So you'll notice that if you go click on normal and underweight in person, we're going to have certain factors defined. There's something called weight index here, okay? And weight index is 1 for overweight, normal and underweight it's 0, 2 for obese. And there's a thing called quality of life down here, just beneath it. And it basically says, okay, if someone is diabetic, we're going to use this variable compared to that one. And this gives the quality of life of people at different stages of weight based on whether they're diabetic or not. Okay? So this is a model that's an agent-based model, but it also includes some system dynamics components to total up costs and quality adjusted life years. So this was of strong interest to those in the room, being a room, many of them health economists. These are the sorts of models we could use to perform cost effectiveness analysis. And for those who are really interested in that, any with health economics bent, you'll notice that there's actually one of these experiments that computes what's called the incremental cost effectiveness ratio from this model based on interventions associated with lowering overweight. So big picture here, ladies and gentlemen, this is a model which depicts the interaction of diabetes and weight. Weight, someone's weight affects their likelihood of becoming diabetic over time. So getting someone to lose weight would lower the risk of them becoming diabetic, and both their weight and their diabetes status in turn affects their quality of life and their costs. And within this model, we could examine the impact of running interventions which, for example, lower their weight, reduced overweight incidence, and we could compute cost effectiveness ratios for them. And that's what this does. And I'm not going to run it out, but it would run, pursuant to the question earlier, this can run, I think, 50 or 100 different runs. You could set it to run 1,000, but I think it's currently set to run 50 or 100 different runs that are assessing cost effectiveness of an intervention. And each cost effectiveness ratio will be a bit different because the savings will be a bit different and the gains in terms of quality of life due to the stochastics involved. So this is a model, ladies and gentlemen, which includes some elements of cost, of quality of life related to diabetes and related to weight. This is an agent-based model. We're depicting individuals at an individual level. Okay? I'd like you to stop that one. People are really interested to continue to run it. The simulation takes a while to run for each one. We're going to close this model, and I'm going to ask you to load another one. Okay? This model that I'd like to ask you to load is of different sort. It's one called GIS Food Environment version 6 with adding supermarkets. Okay. GIS Food Environment. I asked you to download that before. Do you see that? Okay. If you could open that up. This model has a feature that's notable. Okay? And for this feature to really be usable, okay, I have to go change that. Ladies and gentlemen, Unfortunately, the service provider changed after July. So I'm going to go click on this. So I open Maine. Here's Maine. I'm clicking on this, and I am going to provide the tile provider. I'm going to change it to OSM Classic. And what that means is I won't get those messages. It'll be able to load in a map. This is a GIS integrated model. What I mean by that is this is a model which incorporates geographical information systems information. So what is this model going to depict? Well, we're going to have an environment, and we're going to have people located within a geographic space. They're going to have homes, and within this geographic space is going to be a depiction of the food environment. Not the environment that's being set up at the back there, but the environment within the city that's depicted, which is Melbourne. We can easily modify this to depict Saskatoon. In fact, in our boot camps here, we build a model like this for Saskatoon. So here, we have two types of resources being depicted. One type of resource is a supermarket based on actual locations of supermarkets in Melbourne, Australia. And the other is a depiction of convenience stores. Now, the types of food that you get in each of these locales is different. In a supermarket, you have access to fresh fruits and vegetables. In a convenience store, in the Australian context, you have access to pies and floaters if you're in floaters. I get mixed memories on it. Floaties or floaters if you're in Adelaide. These are high-fat, low-nutrition content foods. Here in Canada, at convenience stores, I'm told by my students that you have access to corn dogs. Okay? In short, the food environment is less rich, less healthy there. And so we're going to have here supermarkets and convenience stores at actual locations. And then let's go look at the theory of personhood. Could you look at person here? Double click on person. What you're going to see is a somewhat articulated theory of food seeking by people. So I'd like you, after you click on that, to go take a look at a couple features. They'll be located vertically. The top one is there's a state chart where someone comes in and basically they're not seeking food initially, but then they engage in food-seeking behavior. And we'll see what governs that. And they go either to a supermarket or a convenience store. And this choice here is going to be dictated not only by chance, there's some element of chance, but it's going to be dictated a lot by their preferences and by the distances involved. So the idea is I might prefer to go to a supermarket, but I live across the street from a Max. And so when I'm really pressed, I'd like to go have a healthy tabbouleh salad at the supermarket or something. I'd like to pick up something healthy, but I only have a little bit of time, so I run across to Max and I get a corn dog, something like that. So the idea is that this choice depends here, this probability of going for convenience food. I'm not going to go into it in detail, but the probability of going to convenience food depends on the distance and their preferences as well as some randomness. Okay? It could also depend on the time of day and traffic patterns, for example. We have a similar model. We have a model that has some similar features that you may see this afternoon that we've built in conjunction with UCLA and the Department of Public Health of LA County in Los Angeles. And that depicts people's food-seeking behaviors with respect to fresh fruits and vegetables in the LA context. And their traffic patterns might be more of an issue. So here you can go to these stores, and if you go to a supermarket, you are obtaining a larder of food. This is, again, a model we built in a boot camp. You're getting basically 21 meals worth of food is depicted. If you go to a convenience store, you're just getting one meal. You're going and you're getting that pizza or the corn dog or whatever other things they sell there. And then you go home. Now, what is it that drives their food seeking? Well, you notice if you scroll down, there's a depiction of a decision process. They're going to eat a meal. Which meal do they eat? These are called action charts. They depict kind of the rules, the decision rules that are operating. We use these with stakeholders to try to visually illustrate decision-making in the model on the part of agents. So imagine you have an agent. They're going to eat a meal. How do they decide? Well, the agent first sees, okay, do they have both convenience store and supermarket meals available? If so, they're going to choose it according to their preference. Otherwise, if they only have a convenience store meal, that's what they're going to eat. If only a grocery store meal, that's what they're going to eat. And then, over on the left-hand side, if they don't have either available, they're going to go shopping for a meal. They're going to go replenish their larder, or at least they're going to at least satiate their hunger. So, ladies and gentlemen, here we have a depiction of food seeking. We have a depiction of kind of a simple eating rule. Yes, very, very stylized. This is a model we built in our boot camps, and so it has to be simpler than a full model would be, like the one you may see this afternoon for LA County. But here, finally, there's a depiction of someone's weight status and its change over time. Now, we have a very, very detailed model built by Kevin Hall of the U.S. National Institutes of Health based on exquisitely calibrated to data collected in the NIH involving how people's weight changes over time in response to caloric intake, physical activity. Here, we have a very simple depiction that we can build in a boot camp. Here, someone's weight. The higher someone's weight is, the higher level of energy expenditure at a basal level. Just to kind of keep the body going. You have more body mass. And then there's some amount of energy expenditure from physical activity that depends on a park and your distance to a park, the nearest park. So in this context, we're going to have a food environment that includes supermarkets and convenience stores, but we're also going to have parks, and that's going to shape someone's energy balance over time. Again, toy model, we build it in one day within our boot camps, but it gives you a sense of some of the factors you could include. And if anyone's interested, I could show you a very, very detailed model of this that is actually physiologically very well calibrated and suitable for use in a model like this at an agent level. But let's go check what happens here. So I guess I should finally say they want to eat a meal 3 times per day. So this eat meal event goes off 3 times a day, and they get a hankering for food. Yes?
I was just thinking about when you look at the energy expenditure
Yeah.
by physical activity.
Yeah.
And that variable, it seems as though, is it data coming from a statistical model?
So again, this is the type, I put that in there because it's exactly the type of relationship we might get out of a statistical model. Through certain types of statistical analysis, we would likely get this sort of relationship out as quantified in terms of sort of level of energy expenditure. So you're right that the form of that is from a statistical model, but to be clear, again, we built this in a class in a 1-day period, so it was just illustrative. But the goal here, as with that earlier model where we had hazard rates, which had a somewhat similar form, was to illustrate how you might bring results from a statistical model into the context of a dynamic model. So you can see that linkage without actually professing to have estimated these in fact parameters. Okay? So I'd like to run this model, and I tell you one point of concern that this model was packed up with some additional files, and I want to be sure. I'm actually not completely certain. Oh, look at that. Okay, file not found. It's looking for an Excel file. Okay, pardon me. I'm just going to disable that, and then you'll be able to run it. We modified this in class, I guess in Melbourne, to write to an Excel file the output, and I just want to get rid of that. So give me just 1 second. Here we go. And so where is this Excel file? I should have checked that. There we are. Excel output file. Okay. So we want to, ladies and gentlemen, if you go to main in that model, to get it to run, I apologize for this, I should have been more careful. If you go to main, and you go over within main to the left-hand side, okay? So let me get over there. On the left top, above the map, above this map, the left top to the left of this, you'll see a record outcomes event, which writes to an Excel output file. You can delete both of those, okay? I'm just going to go select them, and then I'm going to delete them. I can delete them with this X up here, delete, boom. Or I can do Control X to delete them, or I can do Edit, delete. But please get rid of those two, because those will prevent it from running. It's looking for an Excel file to output the data, to which to output the data, and I didn't give that to you. So it's illustrative of the fact that typically with these models, they output data to a database or Excel file in addition to displaying. Okay, so let's run this model as the food environment is prepared in the room. Let's go see the impact of the food environment here. So ladies and gentlemen, here we're starting individuals at homes, and individuals live at homes and they are traveling. And you notice when they travel, I will slow this down so you can see it. But as they travel, ladies and gentlemen, they're actually going to be traveling along actual routes. So it actually knows where the roads are. It knows where the paths are, the bike paths and so on. Now you may ask, why is that significant? Well, in this day and age, when people are talking about the impact of the built environment, one of the considerations is if you're walking, you are walking along often a much longer distance in suburbia than you actually need to go from A to B because of the loopy character of the streets and so on. And that may discourage you from going to get food at a supermarket because you have to go this extra long distance. And a model like this can take into account that geometry. It can take into account when planning, where do I go, that it's a lot further for me to go to the supermarket, even though as the crow flies it's quite short. Because I have to go there in this loopy way, it's further than it is to go to the convenience store. So we actually had them going along these routes. Here in town, the impact is even more significant. You think about Saskatoon. If you want to plan, if you're living on the west side, and you want to go to a supermarket, there may be, across the river, Sobeys, but you don't live near a bridge, so you have to go a lot further to get to that bridge. And so the fact that it can plan and computing distance, how am I going to get from A to B, how far is it when considering where I'm going to go eat, that it can consider actual routes has significance. It's not merely a kind of toy thing. But you'll notice these individuals moving back and forth through the routes here. They're moving back and forth. They're going and replenishing their larders at supermarkets. They're going and visiting convenience stores based on their preferences. And they're actually traveling long routes. Now, if we go down and we look at, we can actually scroll around here and you'll see these individuals kind of moving. If we speed things up, one of the things you'll find that's a bit disconcerting is that some of these individuals acquire a rather different form than others. So this is a depiction of their weight status. We do see a different shape associated with them. And if you scroll up in this, what you can see is some illustrations of kind of the mean weight across the population summarized here. We have a different version of this model that takes a look at different associations. This is notable pump. I don't have it here, but I can give it to you very readily. There's a version of this model that includes not just mean weight across the population, but it looks like association. So it looks like an association of how far is it from the convenience. So if it rates for a given person, how far they are from the nearest convenience store to their weight, or how far they are from the nearest grocery store to their weight, or the ratio of distances from the convenience store to the grocery store, and compares that to their weight. And each person is a dot on that. Unfortunately, I didn't give that version to you. But the point is those associations which emerge from that could be compared with empirical data, where you actually have some information about people's weight gains in a built environment where their distance to the nearest grocery stores or convenience stores are shown, and you could look and you could compare that to the model results. So this is a simple model. It's a simple teaching model that depicts some representation, a simplified representation of the impact of the urban form, the impact of the food environment on people's weight change over time. And perhaps it goes without saying at this point, although this model did not depict chronic disease outcomes, there's no reason in principle that in addition to this state chart here associated with food seeking, we couldn't have a state chart associated with chronic disease, associated with heart disease or associated with diabetes. And the longer that they stayed obese, the higher the risks would be there. And we could trace through the impact of the urban form all the way from impact on day-to-day eating habits to weight gain to health outcomes and chronic disease, all the way, in fact, to mortality. So this is an illustration of a model that uses GIS data, such as many of you might have used in other contexts, to try to understand how it might impact behavior over time at an individual level and at the level that's implied for overall population epidemiology. One of the models that we just presented, Kurt just got back last night. In fact, this morning, I think, about 1 a.m. from APHA conference in the States, where he was involved in a presentation of some work that he's done with UCLA, and it's in a collaboration also with the LA Department of Public Health, involving food environment and sort of decision making on the part of a mother and child. Although I think the food environment is less articulated in that model, but also in that same session, there was a model depicted of the food environment in LA, constructed by another one of my students, Winchell, that used a GIS type representation, but was actually tied in with data related to women and children program in the States to support healthy eating, amongst other things, in the youngest years. So, ladies and gentlemen, a model of dynamics associated with GIS data. Here we have a quite articulated depiction of decision making when it comes to day-to-day choices for eating, and we can link it through logically to weight gain. So decision making on eating, decision making when it comes to food choice and sort of where to food procurement. Kurt's working on another model which involves quite active decision-making with respect to tobacco procurement with the NIH, and I'm sure you could comment on that to people who would be interested, and then tracing it through to weight gain. This is an agent-based model. It has a hybrid component. This is stock and flow. This is system dynamics within an individual. But it illustrates the power of the agent-based approach into situating individuals in textured environments where resources are situated, parks, food resources, and where individuals are situated in somewhat realistic environments, just like that model presented at the APHA. So, agent-based model. Okay? One final model type, and we will be released to the, I'm glad to see there's no corn dogs back there. Okay? Okay, so ladies and gentlemen, I'd like you to load in one more model. This model, in the interest of time, I'm actually not going to ask you to go get one from the site. I'm going to ask you to go to Help menu and go to Example Models. Okay? So Help Example Models. And how did I do that? Help Example Models. Not any logic help, but example models. People okay with this? Are you back to this? Okay. I'd like you to go on the left-hand side to examples, and there's something called healthcare. Do you see that? On the left-hand side? Okay? If you click at healthcare, there should be examples that appear over here. And there's some interesting ones here. Needle sharing and alcohol addiction and use, chronic treatment, pharmaceutical pipeline, hospital admissions, diabetes progression, etc. I'd like you to go to the first one, though, trauma center. Okay? This, ladies and gentlemen, is going to depict the third major sort of modeling. Agent-based modeling, ladies and gentlemen, depicts the type you've just seen, depicts one or more populations of individuals. Those individuals interact with each other through the environment and sometimes with the environment directly, shedding prions to the environment or acquiring MRSA from the environment or what have you. This final type of modeling, like agent-based modeling, is articulated at an individual level. This final type of modeling is known somewhat confusingly as discrete event simulation. Okay? We're going to go through this in the interest of time, but it's discrete event simulation. Okay? And discrete event simulation depicts workflows in a structured fashion. Often this sort of modeling is something that health practitioners who do value stream maps or who work with structured depictions in business process language of their workflows will recognize. So we depict stages of work in a workflow. So perhaps it's individuals being taken in, being triaged, being waiting for examination, being examined, etc. So we have these particular steps. And ladies and gentlemen, the workflow proceeds only in a resource-constrained way, typically. What I mean by that is, in order to proceed to the next stage, often you need to have a resource allocated to you. So an example would be, you're supposed to have an X-ray taken. And you can't get the X-ray taken until the X-ray machine, the X-ray area is free to take a patient. If someone else is in there, you can't go in there. So you wait. Or maybe you need a workup by a physician, and you have to wait until the physician is ready to see you, and then you can proceed. Or maybe you're waiting for a procedure room, for some work to be done on you as a procedure, and you can't get into that procedure room until it's free. So often within a health context, whether anything from gurneys and wheelchairs to MRI machines, your ability to progress through stages of care workflow is contingent upon resource availability. Those resources are sometimes human resources, doctors, nurses, clinicians of different sorts, allied health professionals like OTs, PTs, social workers or what have you. In other cases, sometimes it's physical fixed resources, the MRI machine, the X-ray facility. Other cases, it's portable things like a portable ultrasound machine that has to be brought. But it's resource constrained. And what happens is, if people need that resource to proceed and they can't get it, what happens? They get queued. They wait. They await treatment in a line. And so this sort of modeling focuses a lot on queues. Patients flow through a facility and the processes kind of operate upon them. In agent-based modeling, they're actively interacting with each other. Here, they're mostly passive. They kind of flow through this workflow and they're operated upon. And a lot of the interest is in the resource use, for example, how long they spend in the system for the entities and how many resources, how well the resources are used. So you often have limited resource pools, okay? So let's go take a look at this example as we wrap up here. So here, if you go open main, you'll see a depiction of a trauma center. Now, Kurt has a very nice model that is kind of the same facility that we saw depicted in system dynamics modeling a few minutes ago. He has it depicted in this type of modeling as well, discrete event modeling, which we could show you if you were interested to see the outlines of it. But in this case, this is a built-in model from AnyLogic based on a real facility where they did work. And And this depicts a center which involves different types of treatment. So you have emergency department here. Excuse me. You have some facilities like X-ray facilities here. There's an express care area. There's a waiting area. And people come in one of two ways, walk-in or ambulance, and they're discharged to this area here. Now, what I want you to watch is this type of modeling is often integrated with a very intricate visual depiction. So if you go and you run this model, we'll go and run the simulation that's available. What you will see is a sort of progression of patients as they arrive and as they go through the facility. But not only will you see the patients, the so-called entities, as they flow through, you will see the resources that operate upon them in terms of doctors and nurses. Now, we can depict this in either 3D or 2D. And on your machines, it probably will work fine in both. I think in mine, I'm going to have to switch to 2D because there's some aberration. But I think at 3D, you should be able to see it. Yuan Tian, who's doing the work for the Ministry of Health, she has a quite detailed depiction in sort of using those 3Ds for some of the facilities here in Saskatchewan. So let me slow this down. What's going on here? Well, you see some patients waiting over here in the area. They go to this, here's someone coming in, they go to an area to check in, and then they're going to go back to the waiting room. And going back to this waiting area, they're going to wait care, and then periodically they'll be taken out by a clinician and brought to some area for further examination or sort of interviewing. So here they're going through some workflow. Behind the scenes, ladies and gentlemen, there's a depiction, and you don't have to look at this, but I'll just orient you to it. There's a depiction of the workflow processes associated with each of these areas, okay? So here we have within Maine a variety of features, but in addition to that, we're going to have a set of workflows associated with treatment of individuals in these areas. So here, ladies and gentlemen, you'll notice statistics are being taken here. How many are currently in the waiting area? How many are currently undergoing express care? How many have been discharged, etc. And you can click over here to the statistics area, and it will give you indication of how much utilization different resources have seen. In other words, to what degree nurses are being used, what fraction of the time are nurses in use. This is the length of stay of individuals within the facility. Here we have number of minutes which they've undergone. Over here, you could see the process. This is a depiction of the successive stages of workup of a given individual, the workflow, as it were, where they walk in, they enter either via an ambulance or with walk-in, and then they're triaged and they're going to a waiting room, and then they have to undergo what registration, they go back, and then they release them. And if they are going to use express care, they go through a process there of being allocated a nurse and going to a room and releasing the nurse. They have to be allocated a room, and if they're not available, they wait. So you can see here, for example, statistics on the number that have come in here and the number that have left. So this is a depiction of different parts of the process. In fact, there are 5 depictions here. And this provides some further information at a more sort of implementation level. Go back to statistics. You'll notice that this is kind of the equivalent of the CTAS scale, the acuity scale. And here we have the different progression in terms of what hour of the day it is and the patterns that we see in terms of time. I'm running this thing flat out. If we were to slow it down, this is virtual time mode. It runs as fast as possible, but we could slow it down and run it at a slower pace if we wanted to see the dynamics by hour of the day. Notice also we can change assumptions about the number of doctors on staff, for example. we could increase the number of doctors and see how that affects utilization or the number of technicians. All of this is taking into account the fact that it may not just be doctors that are the bottleneck. You might have 20 doctors, but if you only have 2 rooms to see patients, you're going to be waiting for the rooms, not the doctors. So there's these shifting bottlenecks. They're entangled, to use the words I used earlier this morning. And so a model like this can help you figure out, what level of resources do you need for different resources? Where are the bottlenecks? Where do we really need to improve things to speed up the flow, to lower the length of stay, to lower the waiting time? What resources will really make a difference? We can perform a sensitivity analysis on this to understand how do those end up affecting, length of stay. And you'll notice the number of resources are quite large because the workflow is quite involved. And you notice it's branching. Some individuals, for example, come in ambulance, some come in walk-in, and that makes a difference. So here, ladies and gentlemen, we have a quite detailed depiction of workflow, and we are asking fairly tactical level questions. What does our resourcing have to be? Why would you do that? Well, it allows you to identify the impact on health service delivery of a level of resourcing. How many resources you have? How many doctors on call? How many nurses? How many rooms? How many ultrasound scanners, etc. Level of resourcing. Coordination of resources. How do we allocate these resources so they're used most effectively? Even the placement of resources. In this sort of model, ladies and gentlemen, the time that it takes for a person to get treated is a function also not only of the level of resources, but how long it takes them to get to their room, how long it takes the doctor to go fetch the equipment needed to treat them. And with this sort of modeling, you can look at the impact of resource placement. Where is it? What's the layout of the facility? That can actually, you can understand if you change the facility layout, how does it ripple through into length of time, length of stay, or into waiting time for patients, etc. So quite detailed depiction of the dynamics. I know Yuan Tian of the Ministry of Health project that I've been advising for a couple of years now using modeling, the one that Kurt worked on at the back there, and now Yuan leads as the modeler. She just built a model like this for Tisdale to understand some of the dynamics of their facility, and she has similar models for several other facilities here in the province to reason about flow. Finally, this sort of modeling doesn't require a lot of programming. We didn't really touch on that. Agent-based modeling tends to have somewhat more. This tends to have somewhat less. Still a lot graphical in both cases, but this has less sort of computational needs. Okay? I think we'll leave it there. 3 types of modeling, 3 different sorts of models, often different goals for these models. These models are not just different ways of depicting the same situation. They often aim at different goals. System dynamics were often aimed at changing people's mental models, how they think about the situation, improving stakeholder confidence, buy-in, involvement in the process. We're interested in engagement with stakeholders, and we use very simple models to communicate with them. Agent-based modeling, we're often very interested in inter-agent interactions, aspects of their history. We're interested in the ways in which those interactions between agents within populations lead to the overall patterns that we see. And a lot of that focus is on that kind of inter-agent dynamics, as well as dynamics within agents, which can be highly heterogeneous in a way that would not typically be possible with system dynamics aggregate models. Discrete event simulation, extremely effective for dealing with these sort of situations where we have an interest in defined workflows. This can work really well for an ED. It tends to break down for a whole hospital. It tends not to scale because the rules get kind of loosey-goosey sometimes. People who are medicine patients get paced in surgery just because the beds aren't available. So there's a limit to how much you can depict with structured workflows, but if you have a situation that needs it, you can do a lot. You have resources at center issue, and you're interested in queuing and resource utilization. Discrete event modeling is a great simulation. It's a great technique. The best news is, in the models that I shared with you, in the models that you'll hear me discussing online, often what you do is you mix these methods. So you have part of the model depicted with discrete event modeling, part with agent-based, part with system dynamics. You weave them together with different components of the model. So it's not an either or. You use each for a different area of your model. And as time allows after lunch, we'll see examples of this, where we have agents in the population health evolves at an agent level, and then they present for care within discrete event depiction of a clinic or another facility. Okay, so that's all for now. We're going to be breaking for lunch. We're going to try to make it a quicker lunch. We're privileged to have some guest lectures this afternoon for the new generation of modelers. And we'll be able to have some time to pursue some additional exploration as well. So thank you very, very much. Bon appetit. And I hope the food environment is conducive to health. That's right.